Good afternoon to each and every one of you who have logged in for this webinar, which we have every fourth Tuesday. We are so happy to have a lovely panel. I wouldn't say a panel, a lovely symposium on male sexology. We have 4 eminent speakers and 2 great chairpersons who will be handling the program for the next 1.5 to 2 hours. We are confident and hopeful that we will be able to convey to fertility interested clinicians as to how to handle a male factor. A lot of times, male sexual problems are underplayed, not discussed in detail with the couple. And a lot of times the male is hesitant to express during a consultation that a problem with erection or ejaculation is happening. And even if the problem is expressed, most of the time they're sent to urologists who may be practicing more of urology rather than andrology. So today, a unique field called uroandrology is strongly developing to address the needs of male sexual problems as well as male fertility concerns with respect to abnormal semen parameters. And it's a privilege to be handing over the session to Dr. K.D. Nair. And as IFS Tamil Nadu Secretary, I'm so glad that we've been able to get the consistent support of SHIELD to be doing these webinars on a regular basis every month after month. I request Dr. K.D. Nair, our current president of Indian Fertility Society, to take the proceedings of the first session. It's a very proud feeling to introduce him. He's very approachable just with a ring of the phone. And he always is ready to listen to our concerns. And maybe that factor has helped him to be a great teacher. And through Amity, he has encouraged students to come up in the field of reproductive medicine as well as embryology. And with respect to ASRM and ESHRE, there have been regular presentations and regular award winning. That's why he's the star award in the last 2 years, 2020 and 2021 from ASRM. And he is the senior consultant and HOD of Akanksha IVF Center. K.D. Nair, sir, I request you to introduce the speakers and take charge of session 1.
Good afternoon, ladies and gentlemen. It is my proud privilege to welcome all the delegates to this webinar. This webinar on a very special topic, the sexology. And we are going to learn about the sexology problem which are affecting the male infertility problem. I must congratulate Dr. Rajapriya for organizing this webinar and other office bearer of the Tamil Nadu chapter and my dear friend Dr. Gopinath, who is there as a chairperson. I welcome all of you and I look forward to the briefing on this webinar to see how our perception and knowledge is going to be there, how to deal with the male sexology problem, because that is one of the main issues which generally we are in our OPD. We are hesitant to even ask the male. I think we all have to start learning how to ask the male sexology problem. I look forward to this webinar myself. Thank you. Thank you, Dr. Rajapriya.
Thank you, sir. Sahidi, can you play the introduction of the first speaker? Sir, can I request you to introduce Dr. Karthikeyan?
Yes, Dr. Karthikeyan is MCH from Bangalore, MRCS. He's a microsurgical andrologist and urologist at Apollo Hospital, Chennai. He has done clinical fellowship andrology at Rio Men's Health Center under Dr. Vineet Malhotra. Vineet Malhotra is from Delhi. And he has done observership in University of Miami, male infertility diploma from Brazil. And he is a member of a lot of societies. And he has publication in Index Journal, almost 80 PubMed, 56 PubMed publication. Welcome, Dr. Karthikeyan. We look forward to listen to you.
Thank you, sir. Thank you, madam. Thank you for the opportunity and thank the IFS for having thought about this webinar. This is going to be an important session because we ourselves come to know what exactly we need to deliver to our patients and whenever we talk to reproductive medicine experts. So this first topic will be an approach to male sexology. So the scope of andrology in that sexual dysfunction is a separate domain altogether, and we deal with difficult erection, premature ejaculation or anejaculation, sometimes retrograde ejaculation and Peyronie's disease, an upcoming topic of oncosexology. This is the scope of sexual dysfunction, and under male sexology, whenever we see patients, we have to keep all these things in mind before we proceed. So the goals of evaluation will be to identify what is causing this problem, what is the severity of the problem at present, how well we can treat it, and how do we decide the treatment plan. So the treatment will as such be covered in the next talks. So I'm going to restrict myself to mainly history examination and lab evaluation. That is going to be the main focus. Next will be going on to the history. We have main two focus. One is on erectile dysfunction and second is ejaculative dysfunction. So as in every history, we take the duration, severity, what are the associated symptoms, etc. That is what we routinely go through. In that, whether it is a gradual onset or a sudden onset. All these things are done to, because the treatment and the evaluation, everything starts hand in hand when we start the history taking itself. Most of the andrological diagnosis is made at the end of history. And we have to classify our problems, decide our treatment, decide our medications. All these things are done at the end of history and a brief examination. So the presence of libido is again very important, because if libido is present, then it rules out many causes like say a low testosterone, a high prolactin. All those things are reasonably ruled out at this level. Even though it is not 100%, then we go by this algorithm where we can have the investigations to a minimum. At the same time, we extract maximum information from the history. So going into specific details specifically with regard to erectile problems, we have to ask what brought the couple to us or what made the man visit us. Whether it is a difficulty in initiating an erection or maintaining erection. That is again very important. Initiating an erection sometimes may have something to do with say a vascular problem, a neurogenic problem, etc. While maintenance issues can be more or less psychogenic or even diabetes, etc. Again, the frequency of intercourse and the number of attempts per intercourse are important, because that decides the treatment. What is the treatment plan, whether it is a daily treatment or a SOS treatment, and what is the relationship with partners. If we also consistently see patients sorry, who come and say that my erectile problem has started after the marriage, and then we go deep into the history, they say that I had a previous partner with whom I was okay. There itself, the diagnosis is clinched that it is probably psychogenic. Even though in the next 5 to 6 years, he would have developed some organic issues, that component of psychogenic thing is also there. And consummation is again a very important thing. We would have evaluated them for infertility, both from the husband and wife side. But sometimes this consummation history may be missed at times. Because of a busy OPD, the patient not coming up with the things, and they not understanding what we exactly mean. That is also an important thing. And again, masturbation comes into picture, because there is often a masturbatory guilt associated with ED. Second thing, sometimes it is difficult to give a sample for semen and so on, and that masturbation thing also comes into the history. Orgasm and ejaculative dysfunction as such are very important histories. Sometimes we may face with the premature ejaculation or a delayed ejaculation, situation and ejaculation. These are the various categories of ejaculatory issues as well. So how do we objectively assess these patients? We have a detailed questionnaire called the IAEF-5, that is the sexual inventory for men, which contains 5 questions, 5 answers each. And there is a classification which says no ED to severe ED. We also use the erection hardness score like this, which says that what is the erection at the time of penetration, what is the maximum thing you get. This gives us a quick idea as to what we are dealing with, because this questionnaire may be at times difficult for the patients to understand, comprehend, and it requires our help also at times. But this erectile hardness score is mostly followed, like patients are able to follow it and give their suggestion. So we have evolved from IAEF to EHS. Nowadays, we are more focusing on the EHS rather than the IAEF. And examination wise, as we routinely do for any erectile dysfunction, we do the BMI, waist hip ratio, etc., blood pressure, focused examination. And in younger men, probably secondary sexual characteristics and gynecomastia are more important. On examination point of view, the stretched pineal length, presence of plaque, phimosis, and curvature. These are more important. And in infertility case or a hypogonadism patient, testicular volume also comes into the picture where we use a orchidometer. So this is basic history and examination, which we have to focus in all the men who are presenting with sexual dysfunction. So stretched penile length is between two fixed points, that is the pubic bone and the coronal sulcus. This is what we measure. And there are men who repeatedly complain telling that my penile length is not adequate, it is becoming shorter. All those things can happen either because of an erectile problem, too much concerns or thinking about the erections, or in men who have a suprapubic pad of fat, again the penile length shows low. So these are the people where this measurement and showing them the penile length actually offers a good satisfaction to the patient. Similarly, Peyronie's plaques also are identified during examination. So at the end of history and a brief examination, with the idea of about comorbidities and the duration of the problem, the presence of a partner actually improves the history taking. With those inputs, we can actually come to a fair conclusion whether it is a psychogenic, organic, or a combination of both. Nowadays, most of them are a combination rather than pure psychogenic is that is very prevalent in the younger population. So ED cannot be fully dichotomized into these two categories. However, we can have a fair idea as to which component is more. So that is how the trends are changing. And even though earlier they used to say that early morning erections are lost only in organic ED, even in severe psychogenic ED, sometimes early morning erections are not there. And it can be the psychogenic ED also can be for a longer duration. All those things coexist in both the things. And one more thing will be, what are the types of organic ED? One is vasculogenic, that is arterial or venous. Then the cavernogenic factors, specifically like the Peyronie's and all those things. Endocrinological, like the hormonal problems, and neurogenic. So say there's spinal cord injury, post-op status like any RPLND, retroperineal lymph node dissection, prostatectomy, all those things also come to the picture here. Lab evaluation will be a basic investigation like the sugars, the testosterone and lipids, and the other investigations will be focused on the patient profile. Off-face cylinder fill test is a our next line of investigation in any patient who comes with erectile dysfunction. We give 2 tablets of 50 mg sildenafil in our office, and we ask them to do step stimulation or masturbation, and at the end of 1 hour, we assess their erection. So this gives us an idea about what is the blood flowing in the penis and how much erection it gets. This gives us an idea again as to how much this drug will work, what are the side effects, so that we can adjust our duration and the dosage of the treatment. This differentiates psychogenic versus organic many times. And this also can help us in assessing the curvature, tight frenulum in patients who come with either premaritally or just after marriage, they come and say we have tight frenulum. And even the masturbatory ejaculative latency time, which can be similar notes about the IELT, which can improve the treatment options for the premature ejaculation as well. Whenever the office sildenafil test cannot be performed, or if it is not working, the tablets are not working, or we know that this patient has already a problem suggestive of arteriogenic ED, at that time the intracaverous injections are helpful. This bypasses the neurological and hormonal influences, and therefore it is easier to assess the erection. We get a fair idea as to what is the penile blood flow. So in men with, say, severe vascular disease, failed testing, very anxious or unconsummated marriage, those who are just fixed for marriage, those who are not doing well on tablets, all these patients, this injection testing comes into the rescue. We also do cardiac evaluation, especially when patients have angina, shortness of breath, and climbing 2 flights of stairs in 10 seconds is difficult, or palpitations, because these things are similar to the effort required for sexual intercourse. So cardiac disease is again, erectile dysfunction is a marker for cardiac disease. So this also comes as a part of the evaluation. So we published our results of the office sildenafil test. And we also have an algorithm which says that once history, evaluation, and physical examination is done, based on the OST, if there is a good response to the sildenafil test, medications are okay. If there is a poor response, if we have identified a cause why the test didn't work, it's okay. Otherwise, we can proceed with the intracavernous injection testing, where we suspect more of an arteriogenic problem. Based on that, we can go for either medicines, injections, or prosthesis. This is a basic algorithm based on which we can classify most of erectile dysfunction into these categories. More importantly is the partner interview, which can actually change the landscape of the case and the couple totally. In up to 50%, it can actually modify the what we are dealing with exactly, specifically the relationship with the wife, regarding consummation, regarding vaginismus, and even in the treatment. If we institute intracavernosus injection at that time, also again the involvement of the wife improves the treatment outcomes. So partner interview and partner involvement in the treatment is also very important. Going on to a short thing about ejaculative dysfunction, we have many situations like this. Unconsummated marriage, the female's family wants a semen analysis, but the man doesn't know to do masturbation. There were never has been ejaculation intravaginally, and the man has never had an ejaculation. Older man with erectile dysfunction or ejaculative problems, and second marriage. These are the main scenarios. So whenever we deal specifically with the case of ejaculative dysfunction, it may be a premature retrograde ejaculation or an ejaculation. And out of this, younger men infertility, we again see sometimes an ejaculation presenting for the first time. So at that time, we again ask these questions: whether do you know to do masturbation? Are you comfortable in collecting a semen sample? Because that is the first time when the male comes and says, I don't know to do it. And if you go back into the history, we may assess and we identify an erectile problem or an ejaculative problem. Then we again go deeply and ask. That time they say that we have not consummated or we have penetrated, but the man is not able to ejaculate intravaginally. And more further, sometimes they say that the man has never ejaculated and he doesn't know about nocturnal emissions. So these things will be dealt in detail in the next talk. So our idea will be to differentiate or identify if it is an ejaculation, retrograde ejaculation, or a premature, and categorize them so that we can then go for the treatment. So this just a brief history to understand this problem. So a 32-year-old husband and a 33-year-old wife. The man, they are married for 4 years, and the man is unable to ejaculate inside the female partner's vagina, and he is able to give a sample for semen. So there are two different things here. One man is not able to give sample. So second patient is able to give a sample, but not ejaculate intravaginally. So managing these patients again, both the things are different, and more questions like say prone masturbation, porn addiction, is there a previous partner, there is a distraction at the time of sex. All those things are also important when we take this history. One more thing will be a female coming and complaining that the man is not able to have a good erection or stay long inside the vagina. And she says that he is able to have the orgasm, but I'm not able to have. And when we ask the male, he says that his erection is also good and the latency time is also adequate. Then we go in deep and we ask them how much foreplay you do and what is the entire thought about this sexual activity. What do you have in your mind? Whether you are able to attain orgasm, and we go in depth and we identify that sometimes the expectations are different or the desire is different, and what exactly the female wants. All these things also come into the picture. Apart from doing the male evaluation, sometimes the female history is again important, which is like shown in this patient. So here the medical therapy plus psychotherapy will actually help. So one more component is some rare patients who come and say that we have testicular pain, tiredness after ejaculation. All those things are also now recognized as what is called as a post-orgasmic illness syndrome. This is by the way. So at the end of our evaluation, say erectile dysfunction or ejaculatory dysfunction, what we do is we have focused history taking. We have the erection hardness score or the SHIM score, whichever is comfortable, we can use it. We also identify history about libido, partner preference, comorbidities, and the control of the disease. Actually, if diabetes is controlled or not, if the testosterone, if it is low, whether it has been improved or not, all those things also come to the picture. Examination wise, stretched penile length, testicular volume, presence of local problems like curvature and Peyronie's plaques, doing office sildenafil test or intracavernosus injection whenever necessary, basic important blood investigations, cardiac assessment, female partner interview. So these are all the important steps in male factor assessment. And we are not specifically covering about the infertility related sexual dysfunction here that falls into this, whatever we have discussed so far. So based on this, we can have a fair idea as to what we are dealing with. What are the prescription medications patient is taking? For example, when he is on nitrates, we cannot give our PDE5 inhibitors. So again, that component also comes into the picture. So overall, we do a thorough history examination and investigations, office erection evaluation, female partner interview, and then we plan the management, which will be discussed by the other three speakers. So I thank the IFS again for giving me this opportunity. Thank you.
So we have some questions for you in the chat box. Right.
Yeah, Dr. Arun is
Dr. Kundavi has asked, can sildenafil be given safely in diabetic and hypertension patients? Because you've mentioned as a screening test, as a home test we can use, right? So do you think we can, if somebody is a diabetic or hypertension, it's in control, can we suggest this particular test for them?
Yes, madam. Because whenever we take the history, we also assess whether effort intolerance is there, whether they're able to climb 2 flights of stairs in 10 seconds, as I told. Okay. When that is okay, if the cardiac function is reasonably okay, we always do, whenever we have a doubt, we do the cardiac assessment. We do at least an echo and a TMT sometimes. If these things are okay, if they are not on nitrates, and if they have no other cardiac contraindication, not a recent MI, all those things, then we can safely prescribe the sildenafil.
Is it okay for us to straight away go for 100 mg, or is it better to step up from 50 mg?
Yeah. So if there is a history of 50 mg, which is causing, if there is a history of problem with any sildenafil or tadalafil, then we can start 50 mg. Otherwise, it is okay to start 100 mg and then downgrade to 50 mg. That is also okay.
And you would suggest them to take it half an hour prior, or like what is the time?
Sildenafil is to be taken 1 hour prior, and it is better taken on an empty stomach. So either 1 hour before, or at least 1 to 2 hours after the food.
Okay, so these basic requirements have to be. Now, how much in your practice do you see that sexual problems is on the rise this peri-COVID time period?
Yeah, many people come
from home as started, right?
Many people come and attribute their symptoms to COVID, but probably it is due to the stress, or it is due to the sedentary lifestyle, or it is more of like the stress which is happening with the work. All those things are probably the reasons. And I don't think COVID is also a causative factor, but we don't know whether it is only COVID which is causing all these things.
So, Gopinath sir, or if a Nair sir is there, you want to add in any more questions, sir, to approach to sexology in men?
It's a very good, very crisp and very clear presentation, Karthik. It was nice. It's completely a different approach to the people who have not been dealing with the erectile dysfunction. And as you rightly made it out, so the sildenafil test is probably the basic. And there was a question asked about the use of sildenafil in a diabetic. But as you rightly pointed it out, you got to do an effort tolerance test to see if there is any underlying CAD. If there is no CAD, you can safely use it. If you feel that there is a CDA, probably you have to switch over to tadalafil rather than sildenafil then.
Fine. Thank you so much, Dr. V.S. Karthikeyan. I think you gave a nice overview as to how to approach this in our clinic. So unless we know how to approach it, then we may not be able to unfold the problem and help them better. And you've also clearly elucidated as what is the clinician's role. Even if she is an infertility practicing lady doctor, she must be able to pick it up. And it is so holistic. It's not just about the man. Sometimes it may be even the wife's too much of expectations also can cause it. So thank you so much. Sahidi, I request you to share the second speaker's CV. I think Dr. Nair is caught with some emergency. So Gopinath sir, can I request you to introduce Dr. Vasan?
Sure. It's a great pleasure to introduce one of my good friends, Dr. Vasan. Anytime when you just call him for any of your programs, he'll be always willing to come, put his best effort, and make sure that he does a great presentation. He is a CEO and medical director Ankur, Bangalore, and Mangalore, India. And he's the academic head of the Andrology Fellowship Program. You will see most of the speakers today has been trained under him in this fellowship. And he is a Chief Innovation Officer. And he has got a program, co-founder for Master Health Pro online academic platform, technology and scientific advisor for XMAS, product innovation company, and positions the non-commercial. He's a president of a South Asian Society for Sexual Medicine, probably a very apt man to be with us today, and a member Stem Cell IRB, IISc, Indian Institute of Science. And over to you, Vasan. We are very eager to listen to you.
Thank you, Dr. Gopinath, and I think that was rather quite elaborate, but unnecessary. Is my screen visible?
Yes.
Okay.
You have not shared the screen yet.
Not yet.
Okay. I thought I shared the screen. I think the Shield people, when they put this one, they disconnect.
Yeah.
So 1 second.
Please share it again, sir.
So they must have disconnected. This is always just 1 second. Give me 1 minute. Just trying to figure this out.
Yeah, it's visible, sir, now.
Yeah,
it's visible.
See, my take on sexual dysfunction has been always different, because I believe I don't think sexual dysfunction is the urologist's domain. I think it is everybody's domain. Basically, because sexual dysfunction is like fever. At the end of the day, I think all of us need to be empowered to understand what is sexual dysfunction and manage it, because we see sexual dysfunction in various ways in our practice. And like a reproductive medicine doctor sees sexual dysfunction, there's a dermatologist who will see a sexual dysfunction, there'll be a physician who sees a sexual dysfunction, there's a psychiatrist who sees a sexual dysfunction. So I don't believe that it is a urologist's domain. Yes, there are certain aspects of sexual dysfunction which come into the urology domain. So what are the clinical challenges a gynecologist faces? Usually it is because the couple are planning for an ART, the male partner is unable to give an ejaculate sample because he's anxious as there is no erection. Or the couple is explained about timed sexual activity for bettering the chances of conception, and man is unable to give an erection during that period. There's always this debate, do we need to go ahead and find out whether it's pathological, psychogenic, situational? Because at the end of the day, you are trying to treat for a specific reason. So for you as a reproductive medicine doctor, I think the need is just for him to have sufficient amount of sexual activity and help him and overcome this crisis. So one of the problems in sexual medicine is we make it very complex by putting in a first barrier of a history, by trying to say you have to take this history, that time of history, you have to look at this, like that. The complexity of the history acts as a barrier. How many of us have the time to go through an elaborate history? And that too, this is also linked commercially to what is it that we are going to achieve at the end of the day by looking at the history in that complex format. That is for a specialist where there is an established sexual dysfunction. So we believe that the current history taking format is too complex and can only be drained by trained consultant in sexual medicine who are far and few in India. And privacy for discussion examination is also perceived as an issue. So what we believe is, this is a new history format which I keep proposing, because it has only 6 questions. And I don't care whether you diagnose psychogenic, organic, mixed. You just need to know whether there is a predominant erectile dysfunction, you have a premature ejaculation, or you have both. So these are the 6 questions which you can incorporate in your practice. Were you able to insert your penis into your partner's vagina? Did the erection last long enough for you to complete intercourse with ejaculation? Did you ejaculate too soon and then lost the erection, or you lost hardness first? How soon do you ejaculate during sexual activity? Is your hardness sufficient, and where do you rate your hardness, and how long have you had this problem? Because it's very important for us to know what is the problem, whether there is a premature ejaculation or erectile dysfunction. And then the second thing you need to know is, once I know there is erectile dysfunction or premature ejaculation, I need to know whether this patient is safe for sexual activity per se. And that is where we believe that sexual activity is according to Bruce protocol, where we believe that sexual activity is equivalent to 1 mile of walking in a flat surface of 20 minutes, or briskly climbing 2 flights of stairs, which is 20 steps in 10 seconds. So if you don't get restless, that means you're fit enough to have sexual activity, fit enough to have, if you're fit enough to have that kind of sexual activity, you're safe to take the medication. And this is equivalent to 4 minutes of your treadmill. So that is what is the concept. So you classify on the basis of exercise ability, which is a simple question, into low risk, high risk, because some people will say some vague symptoms come up, so you don't know. That is when, so there is no need to evaluate anybody with an ECG. There's no need to evaluate anybody with a echo, stress test, because I beg to differ with several people who do this, because I don't think it is necessary. I've never done in my practice. So what is the next step? You start treatment empirically. It's like fever. You don't treat, you go ahead and treat every fever with Dolo 650 or whatever, Crocin or whatever it is. Only certain fevers, when they don't respond, they require investigation. So similarly, erectile dysfunction is starting treatment empirically. Only failures will require a detailed assessment. So this is what we have rolled out, because this is what it is. Patient presents with difficulty in erection. So you have a history which is directed at identifying whether there is a premature ejaculation or there is an erectile dysfunction. And you always look at associated comorbidity, because we know that India is the diabetic capital, hypertensive capital, metabolic syndrome capital, and consequently you need to have a good control, because these are the comorbidities which lead to erectile dysfunction. So the first and foremost thing is ensure that the comorbidity is well under control, and use a recommended history format. Like I said, the only thing you need to know is that there are only 6 questions which you can incorporate in your practice. Obviously, you look at androgenization, either local or general, because you don't want to be dealing with hypogonadotropic hypogonadism or a fellow who is not androgenized, which is a very, very easy thing to do. I don't think you need to strip a fellow to see him. You look at a male, you know, on his muscular build, on his hairy status, you will know whether he is sufficiently androgenized. Then make sure that you have established control over the comorbidity. And then you ask this question, like I said, the Bruce 4 treadmill Bruce protocol of 4 minutes, which is whether he can climb 20 steps in 20 seconds or he can walk 1 mile in 20 minutes without restlessness. If he says yes, he can do that, then initiate with PDE5. Always initiate with the lowest dosage. I beg to differ with my previous speaker, basically because Indians are intolerant to side effects. You start 100 milligram. If he develops side effect, he will switch the doctor. He will not stick with you. The wife will say, this doctor is terrible. He has created a side effect for you. So we do not, the West starts with the highest dosage and down titrates it. I would prefer to start with the lowest dosage and up titrate it, because the side effects are much lesser when you start with the lowest dosage. So we always start with PDE5 50 milligram, and it is usually given as a pack of 4 tablets. So the idea is he takes 2 tablets and sees whether he gets a response. Short-acting PDE5 was suggested to reduce the side effects and increase it to 100 milligram on demand if there is a poor effect. Now, at the end of it, either the patient is happy. If he is happy, he continues to use on demand, unless there is a comorbidity and you want to evaluate him for a cardiac risk, which is also because ED is a sentinel marker. If not, if he is not responding to 4 tablets, obviously you know that this erectile dysfunction requires further evaluation and he goes to a specialist. So this is very simple algorithm which you can build into your practice. At any point in time in the history taking, if he says he gets breathless or he says he cannot walk 1 mile in 20 minutes, obviously he requires a cardiovascular assessment. Whether you do the echo and treadmill or you refer to a cardiologist, it is always up to you. So, and another thing, on-demand therapy was suggested with efforts at lifestyle changes and control of comorbidities. This is very important. Any suggestion we give, we always give on-demand therapy and along with lifestyle changes and control of comorbidities. The only thing you have to realize in your infertility practice is a lot of these men, because of the fact that you are telling them to have sexual activity at a particular date and time, probably there are a lot of people who are also advised to have sexual activity on a daily basis, they develop high adrenergic tone. So the adrenergic tone is very high. So most of them will require something to relax them. Either I usually give a drug called propranolol, 10 milligram BD, which helps to relax them very well. And that is something which is facilitatory, because you have to break the cycle of the vicious adrenergic tone, because these drugs are ineffective if the adrenergic tone is very high. And also at that point in time, in that kind of a situation, his fantasization and the capacity to have erotic arousal is very less. So you have to ask him to massage the penis so that he can get an erection. So these are the two things you have to follow additional to your sildenafil, so that you get over the crisis of either him giving a failure to give a sample which he will be able to overcome in 80% of the time, or to have sexual activity. If he is unable to, despite these measures, then he requires to be evaluated. So the evaluation is done only for those who fail medical therapy, or for people who fail your exercise ability testing, which tells you that there may be a higher risk. So why is this? Who are the people who are at high risk? The only people who are high risk, like I said, India is the diabetic and metabolic capital of the world. So these are the people who are high risk. Because why is the high risk? Because they have an intrinsic either endothelial dysfunction, or they have an intrinsic pulse wave velocity abnormality. That means they have stiffening of their arteries. So consequently, there are, and we know that these same comorbidities which the patient has can cause this. So there are various tools which have been developed to assess both the endothelial stiffness as well as the central aortic pressures and your peripheral vascular resistance and stiffness of the artery. So what is the process care model? We call this as a process care model, which is the evolution of treatment. We always follow an algorithm, because this is very important. You follow an algorithm and assess with a questionnaire, assess cardiac risk. At that point in time, if you feel there is a need for referral, refer him. Start oral medication. You do not need a diagnosis of psychogenic, organic or mixed. You just need to know whether it's ED or premature ejaculation. And then you start with lifestyle modification along with it, and psychology input is given to individuals, because you are looking at long-term therapy, and that is something you can recommend for those patients who require it. So now coming to selecting an optimal agent, though I have told you sildenafil is the best drug to use, but there are certain situations where we use tadalafil, and if you want to manage ED beyond your simple ART practice, then you are looking at sexual frequency. If you have a sexual frequency of less than 2 per week, and you have a predictable pattern, that means you know when you are going to have sexual activity. It's usually in the night, it's usually after the children sleep, or it is usually when you go on a holiday, it's usually on your wedding anniversary or Valentine's Day. You don't have an unpredictable, you don't have a girlfriend who will drop in at 2 o'clock in the morning, or suddenly come. So your sexual needs are pretty much predictable, then you use sildenafil. If it is not predictable, then you use tadalafil, because again, this is because of the long-term efficacy of tadalafil. If the sexual frequency is more than 3 per week, then you use tadalafil 5 milligram and on-demand extra dose. So this is a protocol which is evolved from John Mulhall. So I'm giving credit to him, because this was his protocol which I followed. And again, there are certain people who don't respond. Simply because I'm telling you this, not because of the fact that you should be looking at non-responders, but simple measures. Because 25% of patients do not respond to PD5 inhibitors, and that is something which you should know. And most of them do not respond basically because your failure of adequate sexual stimulation, because none of us have that eroticity in life, and because of the fear, there is a lot of fear of not having a baby, somebody blaming the male, saying that he's responsible. So that is the reason. Or failure to take an adequate dose. He takes 50 milligram then decides it is not working, doesn't increase it to 100 milligram. Failure to wait an adequate amount of time before taking medication and attempting sexual intercourse. Usually, it is necessary to at least wait for. Nowadays, with rapid acting sildenafils, usually the effect comes in 30 to 45 minutes. So at least it is recommended to wait for 30 minutes before you start sexual activity. So just to summarize, I didn't put premature ejaculation. I think I saw Prabhakar talking about it, so I didn't want to steal his thunder. Just to summarize, this is a very practical way of looking how to empower the gynecologist or the RM specialist to manage sexual dysfunction in her or her own setup, to ensure that the final end result is an ejaculation or a successful sexual activity, which is what your primary objective is. Your primary objective is not going to be curing endothelial dysfunction, curing central aortic pressure deficiencies, and so on and so forth. Thank you very much.
Thank you so much, sir. I think that was so crisp, and you just hit the nail on the head. Gopinath, sir?
Yes. Yes, Vasan. You actually, I think you have tailored your talk to the practicing gynecologist who needs to know exactly up to what level you want. Thank you very much, Vasan. It was really a pleasure.
Thank you, sir. Thank you very much.
So at what points the semen collection difficulty when we encounter, right? There are some couples who get stuck at that point. So initially it's motivation. We give them the choice of home collection if they're finding the hospital premises difficult. So should we take this decision that he has a collection difficulty with just one dose of sildenafil, or could we wait over a period of 1 week, say up to 3 or 4 tablets?
See, first of all, collection difficulty may not be because of the fact that there are many men who get a normal erection and are unable to collect because they are unable to ejaculate because of the high adrenergic tone. So it's not necessary that they have an erectile dysfunction. So not necessary that all patients require sildenafil. One of the things is these men, if they have had normal erection, one group who don't ejaculate is because of erectile dysfunction. The other group who don't ejaculate is because they have normal erection, but only the fear of trying to give a sample in a particular situation makes them not ejaculate. So the latter group, which is fear of not ejaculating, usually are able to collect at home, or like I said, we have launched this remote testing facility where you can collect the sample at home and then transport it. So that is another option which is usually available. So they will be able to ejaculate, unless one of the challenges which I find in most of the labs is also restricting the timing of collection and saying you have to bring the sample between 9 and 12, and that is one thing which is very difficult in Indian households, because if there are many men who are non-masturbatory and they also have sexual activity, so if you tell them to bring the sample at 9 o'clock, they are pretty much in the daytime they are supposed to have sexual activity. These are all some of the challenges. So if you look at it holistically, if you are able to break this, then you will be able to understand that. So in those mind, what we do is I use a drug called Archelion, which is salbutamol, along with propranolol. So that is a wonderful drug because it helps relax the brain, and also it takes away the adrenergic tone. And if necessary, we put them on tadalafil just at a 2.5 milligram dosage, because that gives them, why tadalafil? Because it gives them the ability to ejaculate whenever they feel the need, not necessarily when they take the tablet. So it takes away the fact that I have to take a tablet and I have to ejaculate now. So the other group, which is has erectile dysfunction, again I put them on tadalafil, 2.5 milligram BD morning and night. Additionally, I tell them if you need to take a tablet, take 25 milligram of sildenafil at the time of ejaculation. So but most important, like I said, is to break their adrenergic tone, because they have high adrenergic tone, and that needs to be taken care of.
How far you see over-the-counter consumption on a self-decision base, like, okay, I'm going to use it like Viagra, and that I don't have to go to a doctor. The use of
I mean, obviously, this is a huge problem in India. I know that, because a lot of people do talk about this. But I guess, see, this is an Indian culture. if I can not spend, because Indians hate to spend money on medicine or to the doctor. So, and self-medication is very rampant. So I guess there are instances where medical shop owners only give the medication, but I don't know the statistics because I'm not very sure. But what I can tell you is what the pharma tells me, because pharma is the best judge because they know roughly. I think the substitution market where doctor is not even consulted is in the range of 40% of patients.
So there is a request from one of the audience to repeat that alternate drug which you told, which would kind of calm their nerves and help them with erection. You gave a particular combination, sir.
Archelion, Arcalion, Archelion. I think it's from Servier. I'm not sure.
Archelion. I have been using Archelion for quite some time. I use 2 tablets after breakfast in the mornings every. In the initial case, when they just come with a problem, during the process of my evaluation, I put them on Archelion 2 tablets after breakfast. Mostly they are very, very useful, especially when you add it along with the Sildenafil, you really are awarded.
Thank you, sir. You seem to have much better experience than me. The expert speaking there, I agree with him. I use up to 4 tablets, 2 morning and 2 night, depending on the patient. So, like he says, you can use it. Along with that, in very high stressed individual, I also give them Indirol or propranolol, 10 milligram, either once a day or twice a day.
So the Indirol is again like an anti-anxiety related kind of. It relaxes them.
Yeah.
So I guess Dr. Gopinath sir has the advantage that the male partner can open up with their sexual problems more comfortably on the gender-related comfort zone. And as female clinicians, when even the problem lies with the male, it's a great difficulty for the wife to open up and talk about it, get the husband to come to us and discuss about it. But now we are slowly moving to that metro kind of a population. The urban couple are quite open. In the very first sitting, they are able to tell, like, it's just not happening. So I think it is essential for us to start getting equipped to deal sexual problems when it comes to the fertility domain. So I thank Dr. Vasan for having had this great interaction with respect to management of erectile dysfunction. I'm so happy to invite Dr. P.M. Gopinath to be the chairperson for session 2. I've been knowing him ever since my undergraduate, postgraduate days. He's been my mentor and he's a senior consultant at SIMS, Chennai. And he's currently the president of Fertility Preservation Society of India. And if I stand as the secretary of IFS Tamil Nadu, it's credit to him. He was the founder secretary. And he also holds many more positions as the founder president of SOFC. And he's been always academically engaged, and he's a readily available source of guidance. And he has many more achievements besides even entering into MBA Health Services Management. So I would just request Dr. Gopinath to take over the proceedings of session 2. And thanks a lot, Dr. Vasan, for spending his busy time and keeping us updated on erectile dysfunction. Yes, sir.
Thank you, ma'am.
Thank you all. So I am quite sure that all of you will agree. We had more practical and very entertaining session where you will be able to take home a lot of points in your day-to-day practice. Again, coming to a very important topic, ejaculatory disorder management. And it is indeed a real troublesome when you see them practically in your clinics there. To talk about this, we have Dr. S. Prabhakar. He's a senior consultant and a uroandrologist from Salem. And he finished his MBBS from Manipal, MS General Surgery from KMC Mangalore, and he has done his DNB in General Surgery in National Board New Delhi, and he has done his MCH Urology in KMC Manipal. He is a fellow of National University of NUH Singapore, and he is a faculty and delegates in international and national conferences. He has got a lot of memberships, and above all, a nice person. You will see him talking to us, and then the way he approaches to the practical problems. Over to you, Dr. Prabhakar.
Thank you, sir. Thanks for the kind introduction. I thank the IFS board members for giving me this wonderful opportunity to be with you this evening. So I'll go ahead with my presentation. Can you see my screen?
Yes, sir.
Yes, please make it full
Yeah.
screen.
Yeah. Can you see it now? Is it okay? I made it full
Yes,
screen.
fine,
Yeah,
fine. You
fine.
can go ahead.
Yeah, Dr. Rajapriya had asked me to talk about ejaculatory disorders. It's a broad spectrum of encompassing premature ejaculation to anejaculation to retrograde ejaculation. I'll stick on to the most common one, which is the premature ejaculation. So ejaculatory disorders is a broad spectrum ranging from premature ejaculation to painful ejaculation to anejaculation and retrograde ejaculation. One of the commonest things is premature ejaculation. In fact, it is more commoner than erectile dysfunction. Now, I will take you through this process by just through these various steps. I'll be telling you about what it actually means, what is the mechanism of erection, the sexual response cycle, and briefly touch upon the treatment modalities available. So the various bodies like AUA, the ISSM, the DSM, they all have their own definitions for defining what actually premature ejaculation is. So this is the one of the definitions, that is a persistent or recurrent ejaculation that occurs with minimal stimulation before, on, or shortly after penetration, before the person wishes it to be, and over which the person has no voluntary control, which causes marked distress or interpersonal difficulties. Simply put, is a condition in which the entire sexual process of arousal, erection, ejaculation, and climax occur more rapidly, often in just a few minutes or even a few seconds, leaving the partner unsatisfied. So there are three factors which you should be considered for defining premature ejaculation. One is a short time interval between penetration and ejaculation, lack of control over ejaculation, distress felt in one or both the partners. An important index to take to assess is the IELT, that is the intravaginal ejaculatory latency time. Now there is a lot of proposals regarding what actually is the time limit and all those things. Masters and Johnson's way back in 1970 had proposed that if the man has if he ejaculates less than 30 seconds in 50% of his intercourses, he will be considered as a premature ejaculator. Now, the ISSM and the DSM, that is the Diagnostic Statistical Manual of Mental Disorders, and the International Society of Sexual Medicine, they have come out with their theory that if the IVLT is less than 1 minute, and if the individual experiences this in more than 80% of his attempts at intercourse, and it produces severe interpersonal distress, and in acquired premature ejaculation, it is less than 3 minutes as is the IELT time, and in subject to premature ejaculation, it is less than 6 minutes. Now, this is what has been proposed. So the recent survey shows 3 out of 10 men have a problem with premature ejaculation. The rest just think, they really think it is not a problem. Now, this is the alarmity of the problem. That is 9 out of 10 men ejaculate within 1 minute after vaginal penetration, and 1 out of 5 men present with premature ejaculation, irrespective of the age. And if you see these individuals who claim to have premature ejaculation or are found to have, most of them on an average do not last more than 1.8 minutes. Now, this is the normal sexual response cycle in a male. There is a desire, there is excitement, and there is a plateau. Then he reaches an orgasm, and then there is a resolution. Now, this differs markedly from what a woman would go through in a sexual response cycle. They can have a excitement phase, a prolonged plateau phase, multiple orgasmic phases, and then the resolution, which may take place slowly. Now, how is premature ejaculation different from a normal phase of ejaculation? Here you can make out that there is a steep rise compared to the normal ejaculatory cycle in a male. You see steep excitement phase, a short plateau phase, and a rapid ejaculation associated with orgasm. Now, this is coming to the physiology of ejaculation. Now, you know that the sensory input is taken through the pudendal nerve, through the spinal thalamic tract, that is the L3, L4 as the ejaculatory generator. The central control is the medial preoptic area, paraventral nucleus, and nucleus paraganglion cellularis. And it is through the T10 to L2 is the secretory center, where there is emission from the seminal vesicles, prostate, and there is subsequent closure of the bladder neck. And through the S2 to S4 is where the bulbopelvic muscles come into play, where there is a rhythmic contraction and there is expulsion or ejaculation taking place. Now, the ejaculation is usually retarded by the 5-HT2C receptors, and ejaculation is facilitated by the 5-hydroxytryptamine 1A receptors. So PE happens if there are hyposensitivity to the 5-HT2C receptors or hypersensitivity to the 5-HT1A, HT1A receptors, or a low 5-hydroxytryptamine neurotransmission is some of the causes for premature ejaculation. And as you said, as I have pointed out, these two muscles play a very primary role in ejaculation. That is the bulbocavernosus muscle and the ischiocavernosus muscle. And whenever they go into rhythm, you know, there is a subsequent closure of the bladder neck so that there is no retrograde deposition of the the emitted semen into the bladder neck. So there is simultaneous contraction of the bladder neck or bladder neck closure, gradual relaxation of the external sphincter for the semen to be ejaculated out through the external urethral meatus. Now, coming to the etiology of premature ejaculation, it could be a potpourri of psychogenic, there could be urological causes, neurological causes, hormonal, or it could be a side effect of certain medications. Now, psychogenic, it could be due to development. That is, in a young age, the individual could have been sexually abused, or he has a different attitude towards sex, which could be internalized at a very early age. Or it could be individual psychological factors, like he could have a bad body image, he could be depressed, he could be having performance anxiety, and there could be also relationship factors, decrease intimacy with a partner, or there could be partner conflicts. Now, urological causes, usually this is more common with the acquired variety, where there could be prostatitis, or there could be any of the accessory gland infection, or a chronic pelvic pain syndrome, which subsequently leads to premature ejaculation. Neurological causes likely hypersensitivity of the glans penis is one of the other causes attributed. Hormonal, they could be due to thyroid disorders, medication, sometimes detoxification with medication. The use of certain recreational drugs can also lead to things. Now, not many women would agree to this. I look at premature ejaculation as a sign that I'm hot. Now, how do you classify premature ejaculation? There is basically it's a syndrome, so it can accommodate these particular things. That is, it could be primary, which is lifelong. It could be acquired, that is, it develops after a certain period of normal control. It could be a natural variable premature ejaculation, or it could be a premature ejaculatory dysfunction. Now, this is a subclassification of the PE syndromes. It could be lifelong, acquired, natural. Usually, the more common varieties are the premature, like ejaculatory dysfunction, natural variable thing, and the next common is the acquired one. Less commonly, we see the individual presenting with lifelong premature ejaculation. So I will just take you through the major characteristics of each one of the ejaculation syndrome. The lifelong ejaculation syndrome occurs too early and nearly at every intercourse. This is what you have to bear in mind. And with every woman, if suppose you have multiple partners, with every woman, and usually the onset is with the first sexual encounter onwards. And in majority, that is 80% of the cases, ejaculation occurs within less than a minute. And in 20%, between 1 to 2 minutes after vaginal penetration. Sometimes it can even occur even before vaginal penetration. And this is called ejaculatio anteportas. And lifelong PE is a chronic ejaculatory dysfunction. So these people require treatment over a prolonged period of time. Now, the acquired PE, many of us or many of the males would actually go through some form of an acquired PE. Early ejaculation occurs at some point of a man's life. Man usually has had normal ejaculatory experiences before the start of this complaint. Usually it could be due to some kind of, as I had mentioned, about some urological cause like prostatitis or a chronic pelvic pain syndrome or some kind of a thyroid dysfunction. So it is better to investigate in these matters, like a physical examination, blood or urine examination is a must. Now, the natural variable form of premature early ejaculations are not a symptom or psychopathology, but a manifestation of it's a normal variation in sexual performance. Early ejaculations occurs only inconsistently or irregularly. Usually these people require only reassurance and to tell them that like in a form of a psychotherapy or counseling, that early ejaculations are part of our normal sexual performance. Now, there is another condition called the premature ejaculatory dysfunction. It's only a subjective perception of a consistent or inconsistent early ejaculation during intercourse. So he could be preoccupation with an imagined early ejaculation or lack of control of ejaculation. So here, actually, if you look at the intravaginal ejaculatory latency time, it ranges between 3 to 7 minutes, sometimes even longer. Now, these are how to evaluate such patients presenting with it. There are a lot of questionnaires proposed by various bodies, and this is one way we assess that questionnaire. And this is the premature ejaculation profile. So you grade them between 0 to 4. Each question carries a mark between 0 to 4. So the patient himself is able to tell you where he stands. So management of premature ejaculation, psychosexual counseling, technique of and sexual positioning, you can teach them, and pelvic floor exercises, the age-old start and stop squeeze technique of Marston Johnson, the pharmacotherapy, that is medications. This is what we as uroandrologists would be prescribing, and whether surgery has a role. Now, pharmacological options, there are the most commonly used are the SSRIs, that is selective serotonin reuptake inhibitors. These are either the long-acting or the short-acting ones. The long-acting ones are the paroxetine, sertraline, and the fluoxetine, and the short-acting is depoxetine. You have the other one is the tricyclic antidepressant with SSRI-like action, that is clomipramine. We also use PDE5 inhibitors because, as my one of my gurus, Dr. Vasan, used to always say, better the erection, less is the chances of premature ejaculation. So the stronger the erection, he feels much confident. So you can also use Tramadol, which is a centrally acting opioid. Topical anesthetics like the Emla cream and the lidocaine cream spray, which has come into the market, marketed by Cipla, and intracavernosal injection. Suppose he fails with PDE5 inhibitors to have a good erection, you can also add the intracavernosal injection, which could be Mymix, Trimix, or the prostaglandins. Injection of glands, injection with hyaluronic acid is to desensitize. I have no experience regarding this. Now, regarding SSRI, briefly, I'll tell you how it acts. At the nerve ending, the synapse, the serotonin is released, and you should know that serotonin is considered as a happy hormone. So this is, and it is reabsorbed. So what the SSRI does is it blocks the reabsorption of serotonin. So more serotonin is available even for the next nerve cell. So there is, you are basically allowing serotonin to accumulate at the nerve endings, and more serotonin is available for action. So among the SSRIs, the one which has been FDA approved is depoxetine. The only drug which has been approved for use. It is short acting and it can be used on demand purposes. Usually the dose is between 30 milligrams 2 to 3 hours before intercourse, but it can be increased up to 60 milligrams if needed. It has got a low adverse event profile at 30 milligram dose. Usual side effects are nausea and headache. Now, SSRI is looking at the safety profile, the general side effects. We all should know whenever you profile SSRI, because a lot of psychiatrists also use So we and urologists, andrologists use SSRI. So we also need to take into consideration, because there is another syndrome called as a discontinuation syndrome, or the patients who fail to continue taking this because they have a lot of side effects due to taking these drugs, especially on a long-term basis. That is dizziness. And the most important thing is suicidal ideas. This is which you have to take into consideration when you have these patients on SSRIs, and you may have to discontinue or switch over to some other drug like Tramadol. So the Tramadol has got a mechanism of action is binding to the mu opioid receptors, and has got a weak inhibition of reuptake of norepinephrine and serotonin. Usual dosage is between 50 to 100 milligrams, is given on demand, and has got a low adverse event profile. And it can also be given for certain individual who has got some sleep disturbances also associated. So type of dosing: on demand, we prefer Deboxetine, Tramadol, Clomipramine, and PD along with PDE5 inhibitors. And one thing you can mix and match. That is, you can suppose a person has got is unable to tolerate SSRI over a period of time. You can switch over. You can even add on or combine PDE5 inhibitor with Deboxetine. And we have in Indian market, we have these various combinations. Or for daily use or for a long-term use, these are long-acting ones. This Paroxetine, Clomipramine, Sertraline, and Fluoxetine can also be used on a daily as a long-term usage. Treatment option. Now, this is not actually for the fertility specialist, because I just wanted to add on this. Suppose you have various options. Suppose you have an older male who has less frequent intercourse. You could probably give him Deboxetine or Clomipramine, or you can try local sprays. Or if you have a young male who has probably falls into the category of a lifelong premature ejaculation syndrome, or he is a young male, so he has frequent intercourse. So you can start off with counseling him, reassuring him, start off with some exercise technique, because he's a young individual. So stop squeeze technique. You can try psychotherapy. You can start off with Clomipramine and Paroxetine on a daily dose, gradually increase the dose. Suppose he has side effects, you recognize the side effects, you can switch over to the other drugs like Tramadol, and you can try Deboxetine with local anesthetic sprays or gels. Or you can try intracavernosal injection to augment his erections. So you are looking for, I suppose sometimes you have a male looking for quick solution, not tolerating SSRI, he wants immediate relief. Then you can try probably local anesthetic gels and sprays. But one thing you have to tell them is you have to wash it 10 minutes, because otherwise the partner may develop numbness. Now, these are some of the exercises to cure premature ejaculation. Start-stop method associated with squeeze for 25 seconds, and also you can tell them to train themselves when they are voiding several times to stop the flow of urine. You're basically trying to, the group of mother, ischiocavernosus, bulbous cavernosus, you're trying to strengthen them, and you prevent, the ejaculation coming forward. The squeeze technique, I think we all should be, all of us are aware of. You squeeze actually, we have to tell either the partner or the male himself how to squeeze. It's basically keeping the thumb below in the level of the coronal sulcus and depressing it for a period of minimum 25 seconds before he actually ejaculates. That is one more thing which is. And sometimes these people who are using condoms, they don't know how to wear the condom in a proper way. And that could also lead to premature ejaculation. So you tell them how to use that. And these are some of the commercially available condoms which have got local coating. The inside is coated with benzocaine. So these are all long duration. These have been long available in the market. You click on Amazon and can get all these things available to increase the pleasure. And these are some of the desensitizing local creams, gels, and sprays. Now we have come with the spray. Cipla has come with the Lidonair, which is a lidocaine with prilocaine spray, because the problem with the using creams and gels becomes a little messy. So this has come. They have come out with the lidocaine spray. Usually it is 5%. That is lidocaine 2.5% with a combination of prilocaine. Earlier, we used to get the Prilox cream, which was available. Now, Cipla is marketing the spray. So now coming to the outcome, we all know that there is no mortality or morbidity associated with PE. Only thing is it reduces the self-esteem of the individual. It leads to depression and marital discord. It leads to subsequent its subsequent consequences of divorce, leading to divorce also. Infertility in cases where there is no intravaginal or intromission. Very often we see patients, how often we see patients being referred to us from RM specialists with unconsummate marriage or with ejaculatory disturbances. Now, with a combination of methods, including SSRI therapy, improvement or cure should be possible in most cases, provided, I would like to stress, provided that the couple, not just the man, is committed to working on the problem together. Numerous published reports also indicate that counseling and medical therapy can help achieve success rate as high as 85%, matching the high rates originally reported by Masters and John. The problem with all treatment for premature ejaculation is that the relapse rate ranges from 20 to 50%, depending on the study size. Some males may need long-term commitment to periodically repeating the behavioral techniques. Thank you very much. I have a few slides on the other ejaculative disorders because I wanted to, because of want of time, I was just sticking on to only my talk was limited to premature ejaculation. Thank you very much.
Thank you, Prabhakar. Thank you for taking us through an extensive tour of this premature ejaculation, where you need to understand what exactly is the problem, what runs into the mind of the patient, what runs into the mind of the partner, and then just try to pay attention to it. As you rightly pointed out, there are young guys who come with this problem where it is going to be lifelong. It is not just related to an infertility where you get an ejaculation and then she becomes pregnant. You have to look into that long-term use, as you have said. We have to just keep on trying on different sources to make sure that you get somewhere a reversible action there. So that is very, very important.
Thank you, sir.
Thank you so much, sir. So it is like for erection, if we are kind of having a particular, like how Dr. Vasan was saying, there's a pertinent event happening and you want an assured erection like for an anniversary day or Valentine Day, such a thing can never happen with premature ejaculation management, right? It is always long-term. Am I right, sir, to be?
See, the people falling into the long-term category of premature is usually the individuals are, it's less common. What we see more often is the acquired variety, where the individual would have been normal ejaculators, or they would have had normal ejaculations during masturbation. But it's only at times that they develop this, and these can be treated very easily. And reassurance is one of the most important things. And we also would like whenever we see a couple, or sometimes these individuals come alone, I always make it a point when a patient is referred either for infertility or infertility where there is a ejaculatory or erectile dysfunction, I always call the wife at least for the subsequent consultation, because very often when with the male doesn't, because of self-esteem, is not outcoming, he is not he tries to he says everything is fine, but when you ask, and very often the wife sits back and says no sir, she gives sign language. So it's always better to assess them and get the input from the wife, and then take it forward. So premature ejaculation could be one of the problems, also leading to infertility, because there is no deposition, intromission. That could be one of the problems, and it could be easily handled. And basic thing is you reassure the couple, and we have these wonderful drugs, and take care.
How often can it be an isolated problem, or is it mostly coexistent only?
Usually, usually it is. Sometimes people, couples or the individuals confuse erectile dysfunction with premature ejaculation, or vice versa. They could be actually having only premature ejaculation, and because in a male sexual, once ejaculation happens, there is complete resolution. They say they have erectile dysfunction. They say or the woman says he has got erectile dysfunction. So by questioning them, you can easily differentiate what is, as Dr. Vasan had put out those various simple questionnaire, you can actually differentiate whether they actually suffer only from premature ejaculation or only from erectile dysfunction, or it's a combination of both.
Thank you so much, sir. So, Gopinath, sir, if I may ask you a
Yes.
question. A lot
Yeah.
of local anesthetic creams were given to hyposensitize the glands action. Those same creams can be used for the females, sir, if there's some superficial dyspareunia.
No, the problem is, as there was a question in the chat box which has been answered also. So, if there is a dyspareunia, when you use a local anesthetics, what actually happens is the pain component goes off, but the stimulatory effect is completely lost. So they will not be able to do it unless you do a dilatation. Then it's going to be a bit difficult. So the local anesthetist on a female doesn't work that well like that of a male. Male in a premature ejaculation, when you apply it, as Prabhakar rightly mentioned it, to be washed well before she plans for he plans for the intercourse, it's really worthwhile.
So of recent, they started using Botox injections for both
Correct.
dyspareunia as well as P.
Yeah.
So, thank you so much, sir.
Thank
I
you.
think that was a very lucid and very clear talk, that most of the information was shared through your presentation. So, I request you to
The
invite
last
the
topic of the day probably is anorgasmia, which will be dealt by Dr. Arun Karthik Ponnuswamy. He's a consultant uro-andrologist and prosthetic urologist, reproductive microsurgeon and sexual medicine specialist. And he's a director and founder Alpha Science, Alpha Life Uro Speciality and Andro One Men's Fertility Clinic in Salem and Namakkal. He's done a fellowship in andrology and men's health at Manipur, Angkor, under, as we have mentioned it, under Dr. S.S. Basan. And he has done his fellowship in the Committee of Sexual Medicine in Budapest, Hungary, Lisbon, and Portugal. Diploma in Male Infertility in Brazil, North Carolina, and Hamburg, and various presentations in andrology in international and national. And he is going to talk to us on anorgasmia. If you take the couple, mostly they say that everything is fine, ejaculation is normal, erection is normal, everything is fine. But you really go into the detail, more than 50% of the couple won't have experienced orgasm. And in that, the male orgasm probably is misconceived, saying that ejaculation is the orgasm. So if you rightly just inquire and then go through, in the male, probably 50% would have perceived orgasm. In the female, hardly 25% would have perceived orgasm. They don't know how to express it. They feel deficient. This is a very, very important topic where Arun is going to throw a lot of light on it. Over to you, Arun.
Slide is seen, sir?
Yes, ma'am. It is loud and clear. Go ahead.
Yes. I thank the IFS for giving this opportunity. I think when in JAWS I met Raj Premam, we were discussing about we're not having much of talk related to male sexology. I think within a month after ma'am came back, she had planned this webinar, especially concentrating on male sexology. And earlier speakers, they have covered about the approach to male sexology and the erectile dysfunction and premature ejaculation. Coming to anorgasmia, it's a difficult entity, and usually it is difficult for the patient, the male or the female partner, to express about orgasmia. As Dr. Gopinath sir mentioned, 50% of men even do not experience orgasm, and they do not know what orgasm exactly means. And even women, when we have a partner history taking, again, they do not describe what is orgasm is about. So what we need to understand is we should not confuse orgasm and ejaculation, because they are not same and they are completely different processes. But what problem is, we as a clinician ourselves are difficult to find it difficult to differentiate between orgasm and ejaculation. So mostly orgasm is rhythmic stimulation of the body parts which have high concentration of sense receptors. Usually, this is achieved by either physical manipulation of the genitals by the body to body contact, or there can be some vibrotactile devices which can induce this orgasm. The orgasm activities are usually focused on genitals, but need not be the same. Sometimes even it can be achieved by stimulating the other body parts, or even by thought alone can induce orgasm. So the orgasm is usually associated with ejaculation, though the processes are different. But sometimes in case of orgasmic and ejaculation, there can be orgasm, but still there cannot be ejaculation. Usually what the patient experiences, they usually have hyperventilation. They can increase respiratory rate up to 40 breaths per minute. They can have tachycardia, high blood pressure. It is associated usually with the powerful and high pleasurable pelvic muscle contractions, especially the ischiocavernosus and the bulbocavernosus. There can be also rectal sphincter contractions and facial grimacing. The problem is when we ask the patient to explain whether you encounter orgasm, we do not have clearly mentioned what is the exact feeling, and we have to just give him little clue about what are the feelings he can experience when orgasm. This is the biggest problem when we take a history during about the orgasmic disorder in both male or female. Following orgasm, usually there is a release in prolactin and oxytocin levels, but usually the significance of this elevation is not known. Usually they propose this is usually the cause for the refractory period following orgasm in men. So there are various studies for they proposed for physiology of orgasm. The PET scan done to check the blood flow during orgasm, in which they have seen there is increased activation of certain areas in the brain during the orgasm. Especially there is increased activation in the area of the mesocephalic transition zone, which includes the midline, the zona incerta, the ventroposterior, the intralaminar thalamic nuclei, the lateral segmental central field, the supraphagicular nucleus, and the ventral tegment area. Usually in this, there is increased activation seen. Also, there are strong increases seen in the cerebellum areas as well. Whereas in the case of entorhinal cortex and amygdala, there is decreased intensity seen in the PET scan. When coming to orgasm, the quality and the intensity can be variable in different sexual activity in a given individual. Usually the early orgasms, when the initial part of the married life, they are usually less satisfying, whereas the later orgasms are more satisfying because they know how the pleasure associated with orgasm, so it becomes more satisfying in the later part of life. And also, weaker orgasms are seen when there is low level of androgen, as we see in case of hypogonadism, or in an older age when there is low testosterone levels. Following orgasm, there is a temporary period of inhibition of erection or ejaculation. As already mentioned, the refractory period. And it has been proposed that either the prolactin or the serotonin released after orgasm has been the cause for this refractory period. However, there is a lot of debate about this prolactin or serotonin causing this refractory period. So as we see here, the dopamine and oxytocin are the stimulatory hormones for the desire and the orgasm, whereas the serotonin and prolactin are the inhibitory stimulation for the desire and orgasm. So any treatment pharmacotherapy aimed at will be based on this, targeting either dopamine, prolactin, oxytocin, serotonin, which I'll be dealing later. So coming to the definition, the delayed orgasm is the persistent or recurrent difficulty, delay, or absence of attaining orgasm with sufficient sexual stimulation leading to personal distress. The International Consultation of Sexual Medicine also has given a definition which says that anorgasmia is the perceived absence of orgasm independent of the presence of ejaculation. So here again, they have left out ejaculation. Ejaculation can happen or cannot happen, but still patient should not experience orgasm. The DSM 5th edition, they have defined is a delayed orgasm as marked delay in ejaculation in almost all or at least most of the occasions. Usually 75 to 100% of the occasions, they should not experience orgasm. The partner sexual activity without desiring the delay, the individual should not voluntarily delay it. It should be the involuntary delay in the orgasm, and it should be present at least for 6 months and leading to sexual significant distress to individual. The most important thing is this dysfunction should not be explained by any other non-sexual disorder like endocrinopathies or any other disorder, medication, or significant relation life distress stresses. So definition, as for delayed orgasm, there is no set time threshold, but we can compare with delayed ejaculation. To know that, we should know the normal intravaginal ejaculation time. It is usually the median is about 5.4 minutes. Delayed ejaculation is taken 2 standard deviation beyond the median time, usually more than 25 minutes. So whenever the patient complains of the intravaginal ejaculation more than 25 minutes, will qualify him for the diagnosis of delayed orgasm. Incidence is usually about 2 to 11% in men. So for like any other sexual disorder, orgasm disorder can also be classified. Either it can be lifelong or acquired. It can be generalized or situational. There can be mild, moderate, or severe. So as we all know, acquired dysfunction, usually patient had already experienced orgasm before, but currently is not able to experience orgasm. That is acquired one. Situational is that patient experiences orgasm in certain situation is not able to experience orgasm, or he will not be able to attain orgasm with a particular individual. He will not be able to, particular partner will not be able to attain. That is situational anorgasmia. So the causes of delayed orgasm can be various endocrine disorders like the testosterone deficiency, hypothyroidism, hyperprolactinemia, medications like antidepressants, as we already mentioned about the SSRIs, which is given for the treatment of premature ejaculation. They can lead to either delayed ejaculation or delayed orgasm. Antipsychotics, opioids. Various psychosexual causes can lead to delayed orgasm, hyperstimulation, and penile sensory loss. So how do we approach these cases of anorgasmia? So especially in anorgasmia, there is a very important role of sex therapist compared to other erectile dysfunction or the premature ejaculation. We have a significant role. So whenever we see a case of orgasm, we need to rule out organic cause. And whenever we suspect psychosexual characters, we need the proper sex therapist, or even ourselves, we are trained in sex therapy, we can go out and treat the patient. So in case of sexual therapy, the general principles are any given sexual dysfunction, the principle is that we need to involve the patient's partner, and we have to set expectations to the couple. And as already sir has mentioned about the sexual response cycle in the previous presentation, we have to describe him what is sexual response cycle, how does it start, desire, the excitement, then the ejaculation, then there is a orgasm, ejaculation, there is a resolution. This has to be clearly explained to the couple. And most importantly, we need to improve communication between partners. They need to discuss with each other about whether they had achieved orgasm or not. This is the common thing. Whenever we ask a history, the men do not know whether he is able to help the partner achieve orgasm. This is the most common thing. So we need to, every patient, when a case of erectile dysfunction, we have to, even it can be a case of erectile dysfunction or premature ejaculation or anything, we need to have a questionnaire asking about whether about the foreplay, about the penetration, and about the orgasm. This has to be a routine questionnaire in case of sexual dysfunction. So the approaches can be, whenever we suspect insufficient stimulation is a cause for delayed orgasm, we can try penile vibrator stimulation. Sex technique training, there can be, it itself is an separate topic. We have to train the couple for that. Cognitive and arousal behavioral therapies can be taught to the couple. When we feel it is a cyclic conflict, there has to be detailed psychotherapy. Idiosyncratic masturbation. I think in the chat box, I think madam has asked a question about patient is able to attain masturbation like orgasm or with masturbation, not with the partner. This is especially because of the penis is being used to the stimulation by the penis, and it's not able to gain that kind of stimulation with the vaginal penetration. So for those individuals, we have to give masturbation retraining, or we can division of fantasies. Again, there are some people who use the porn, they do not achieve orgasm or ejaculation with the partner. So we have to have the revision of fantasy. In case of desire disorders, again, a psychotherapy is to be used. So coming to pharmacotherapy, there are no defined FDA-approved medication for delayed ejaculation. There are no clinical trials which demonstrate any efficacy for the treatments which I'm going to mention. The problems are because the studies which have been done are small, underpowered, they are retrospective, and they're not controlled. And again, that is, the outcomes are different in different set of population. So the conducting study and proving the efficacy of drugs may be difficult. So the pharmacotherapy, drugs can be used as and when needed, or continuous dosing therapy. The bupropion when we did on-demand therapy, it can be 15 to 60. The continuous dosing can be 75 to 150 milligram can be used as a continuous dosing. Cyproheptadine can be 4 to 12 milligram. Amantadine, either 100 to 4 milligram on demand or 75 to 100 milligram BAD or TAD. Yohimbine 20 to 40 milligram can be used in the continuous dose. Oxytocin, again, is not available in India. It is an intranasal form. 20 to 24 international units can be used. Other commonly used drug is the cabergoline, 0.5 milligram, or it can start from 0.25, increase up to 2 milligram twice a week. And when we have low testosterone levels, as I already mentioned, even hypogonadism can lead to delayed orgasm. So we can supplement them with testosterone injections so that they can achieve orgasm. So I already mentioned the physiology. The entire treatment is based on stimulating the dopamine and oxytocin, or else inhibiting the serotonin and the prolactin. So bupropion and amantadine usually stimulates the dopamine for helping achieve the desire, excitement of the orgasm, whereas oxytocin directly induces orgasm. Cabergoline, by acting on prolactin, the inhibitory effect on the orgasm, it can help the patient reach the orgasm or even ejaculation. The same treatment options are usually used for delayed ejaculation as well. Buspirone is usually acting on serotonin to counter its inhibitory effect on reaching the orgasm. So the general principle in the pharmacotherapy is whenever delayed ejaculation or the orgasm is associated with erectile dysfunction, we need to use PDE inhibitors, as same as that of premature ejaculation. Wherever ED is associated with any disorder, PDE inhibitors plays a very important role. Pineal vibrator stimulation can also be helped. Usually it is about 72% success rate with 3 cycles with 1 minute rest. And the drug effect most useful is that whenever we suspect it is because of SSRIs, we can switch to bupropion. And general drug commonly used, which I use also for delayed orgasm ejaculation, is the cabergoline. So if a patient is on SSRIs, which we suspect that is causing this delayed ejaculation orgasm, we can switch to bupropion, which can be given a 75 milligram per oral, either BD or TAD. The problem with this is the side effects, suicidal tendencies, chest pain, blurred vision, palpitation. If we cannot switch, we can start with cyproheptadine, which can be 4 to 12 milligram, 3 to 4 hours before sex. The side effects are usually nausea, dizziness, urine irritation, photosensitivity. We can also try loratadine, 10 milligram. If the patient is not SSRI, then we can check for the prolactin levels. The prolactin levels either high or normal. Cabergoline 0.25. It can increase up to 2 milligram twice a week can be given. When the prolactin level is low or low normal, we can try oxytocin 24 internationally, intranasally. The other backup agents which I already mentioned, yohimbine, can also be tried. So cabergoline is a D2 receptor antagonist which helps in lowering the prolactin. So it decreases the refractory period in men. In a study by Hollander, 131 men were treated with cabergoline 0.5 milligram twice a week for orgasmic disorder, in which there are 66% patient reported improvement in the orgasm, whereas 34 patient, that is 44 out of 134, did not show any change with cabergoline. Coming to oxytocin, whenever men experience orgasm, there is oxytocin surge. In animals, it is shown to decrease ejaculatory latency time. So in a study by Buriat in 2008, it's a double-blinded placebo-controlled crossover study. 10 healthy men were treated with oxytocin 24 international units intranasally. They checked for the oxytocin, catecholamine levels, and the sexual arousal. There was increased oxytocin and catecholamines following the intranasal inhalation of the oxytocin, and 8 out of 10 men had increased sexual arousal. The only thing is problems we are currently there is intranasal this application not available in India. Bupropion, as already mentioned, this is a drug of choice. Whenever we suspect it is SSRI-induced sexual dysfunction, we can go for bupropion. In a study by Aston Rosen, 47 men with SSRI-induced sexual dysfunction, they were given either 75 or 150 milligram of bupropion 1 to 2 hours prior to sexual activity. When there is no improvement, it was changed to 70 milligram TAD for 2 weeks. So 66% had improvement with on-demand therapy. With patients who did not have improvement with on-demand therapy, there was 38% of patients that improved with prolonged use. 15% of the patient discontinued because of side effects. I already mentioned the important side effects is the suicidal tendency with bupropion and blurred vision, palpitation, chest pain. These are the important side effects which we should note when using bupropion. But other studies had mixed results. What other studies have shown that is the fixed dose bupropion usually works better than prolonged therapy of bupropion. Cyproheptadine, it is an histamine 5-HT and ACTH antagonist. It is used for SSRI-induced dysfunction, sexual dysfunction. Wherever bupropion cannot be used, we can use cyproheptadine. In a study by Ashton, Hammer, and Rosen, 596 patients were on SSRIs, of which they had sexual dysfunction related to SSRIs in 16% of the patients. They were treated with either ohumbin, amantadine, or cyproheptadine. So ohumbin is the results they found is to be that ohumbin was more effective than amantadine, cyproheptadine. Coming to ohumbin, it can be either used to treat erectile dysfunction and delayed ejaculation and anorgasmia. It acts on the spinal cord adrenergic receptors, causing ejaculation. In the study, in 2007, they had 29 men with orgasmic dysfunction. They were treated with 20 mg ohumbin. It is increased to 50 mg if the 20 mg was not effective. 66% of men, that is 19 out of 29, reached orgasm, whereas 3 needed pineal vibrator stimulation to reach orgasm. So to summarize, any case of delayed orgasm and anorgasmia, we need to go in detailed history and physical examination. We need to find the etiology because the treatment plan is going to be based on the etiology. Whenever we suspect pineal sensory loss, we can go for biotheometry or based neurological evaluation can be done. If we suspect this thing, go for a neurological treatment for that. When it is a medication induced, like SSRI, you stop the drug and you go for, if not responding to that, we can go for a drugs, empirical use of drugs like bupropion or cyproheptadine. Endocrine cause is suspected, you do laboratory tests and prove the endocrine cause and then treat accordingly. Whenever it is erectile dysfunction, treat with PDE5 inhibitors, and psychosexual dysfunction is suspected as a cause of delayed orgasm, we can go for a psychosexual counseling, which I mentioned earlier. When is any of this medication, any of this treatment approach does not solve the problem of anorgasmia, we can go ahead with use of empiric use of oral medication. There is not a proven therapy or approved therapy. It is an empirical use of the drugs which I've already mentioned. So lastly, when we're talking about this orgasmia or ejaculation issue in related to fertility management, there are 3 options we can go out with. We can go out with pineal vibratory stimulation or electro ejaculation or sperm retrieval methods, which can be used if the problem is fertility only. So the pineal vibratory stimulation is the direct stimulation of the pineal frenulum area with a high amplitude. It is with 100 Hertz. Usually the best candidate for the pineal vibratory stimulation usually is that as a complete spinal cord injury with an intact ejaculatory system. This is because to pineal vibratory stimulation to act, the ejaculatory reflex system should be intact. So these are the vibrators available. There are local other massages can also be used, but the problem with the routine common massages which is used for this purpose is that the amplitude is very less. The Ferticare and Vibrate are the high amplitude vibrators which can be used. So various methods can be in a Ferticare. There is only one pad, so either it can stimulate the dorsal aspect or the frenular aspect can be tried. When there is no improvement with a single Ferticare vibrator, there can be 2 vibrators can be applied both in the dorsal and the frenular aspect. The advantage with the vibrate is it has 2 vibratory pads. Both can be applied simultaneously, both on the dorsal and the ventral aspect of the penis. So coming to electro ejaculation, I do not have any experience with that, but the problem with this is it should be done general anesthesia with a full muscle relaxation. You need to have adequate lubrication and the bladder has to be emptied before the stimulation. The rectal probe is inserted facing the side of the prostate and seminal vesicle. There can be repeated stimulation can up to 25 to 50 volts, and the prostate can be massaged or the posterior urethra can be milked so that the semen is ejaculated. But with the various studies proving the quality of the semen following electroejaculation is not, the results are not good with the IVF efficacy. So usually we go ahead with the sperm retrieval in case of fertility issues with ejaculation. To conclude, the orgasmic function is dependent on interplay of numerous neurohormonal and physical factors. As already mentioned, non-epinephrine, serotonin, dopamine, prolactin are the primary neurohormones involved. The entire treatment, the empiric medication is based on stimulating or inhibiting these hormones. Delayed ejaculation, anorgasmia can be caused by many medications that in history taking we should be particular about, especially the SSRIs and the psychiatric medications history should be taken. The treatment includes psychosexual and medical therapy. The medical therapy for delayed orgasm or delayed ejaculation are not clearly studied, and the drugs which are currently available not FDA approved. In case of sperm retrieval, pineal vibrator stimulation can be used. If that doesn't work, we fail, we can go for sperm retrieval if fertility is the only issue. Thank you again for the wonderful opportunity.
Thank you, Arun. Thank you for a very nice presentation on a most difficult topic. As I mentioned it earlier, neither the patients nor the treating doctors understand the importance of orgasm, because the moment you get into an ejaculation where there is a deposition of sperm, they feel probably the job is done. That is the way they just generally normally look at it. But there are various other aspects which, as you have highlighted it, it has to be really important and it has to be looked into it. So as far as the last part of your talk on this 7 sperm retrievals, so the electroejaculators, as you said, it is cumbersome. It produces severe asthenospermia when you just take it. So that is the reason it's also huge and mechanical, and then that's the reason it has not been preferred. The pineal vibrators, not necessarily the standard one which has been used for it, ordinary ultrasonic vibrator, which is hardly cost about some 700 to 800 rupees, are available in the market now. All you have to just try to just keep them under that's what we do it for the collection if there is a difficulty. Even for a fertility preservation, when we get a young boys, say just around 13, 12, which they have not, we always give the first shot with the pineal vibrators and then see whether we are able to collect it. And most of the times we'll be able to collect it. So failing all this, probably yes, the sperm retrieval techniques in the form of a teaser and NISA will be really useful. But first, we have to educate the couple about what is erection, what is ejaculation. The science does not stop there, and there is something called orgasm. Yes. And then we have to take an history and see how many of them perceive, how many of them are truly interested in getting it perceived, and then probably we have to change the direction. It is really indeed a challenging task when compared to the premature ejaculation or any other form of sexual dysfunctions there. Yes, Priya?
So I felt like we do not have enough well-trained psychosexual counselors, and that's one reason why pornography or alternate quack practice or sex toys on Amazon come in, and it may not meet the expectations of the concerned affected person. And with this new social media world, I don't know how far they're all experiencing such people trying these devices and not satisfied.
Thank you. Thank you very much. And it was indeed a very, very useful academic session in the last 2 years to us. So I thank IFS and Rajpriya for having taken interest and then arranged this program. Thank you for all the participants. And thank you, Prabhakar, and thank you, Arun, who have done an excellent job in my session.
Thank you, sir.
Thank you so much.
Thank you,
It
sir.
was indeed it is an honor to have you as one of our chairpersons. Thank you, sir.
And I must say, this is such a sensitive topic. Generally, when we talk about sexual medicine, which is relating to either the male or the female, it's a very sensitive topic, and nobody wants to address this question because they know they're opening a Pandora's box. And suddenly the clinician will feel the gaps in the knowledge, or they become insecure as to how to proceed further. And we do not have sufficient hands to deliver this kind of a niche service. And I'm very glad that we are slowly having a lot of uroandrologists to just not look at the sperm, put it inside the egg and get the baby, but beyond it, to be able to create a sexually satisfied couple, and that's what the whole seminar was about. And thank you so much to all the speakers, and thanks, special thanks to the chairperson, Gopinath sir, stayed till the very end. And if there are not any more questions, I do understand that we will all have to rush back to our evening practice. And thanks for being here around this tea session. Thank you so much.
Thank you very much.
And thanks to Shield Pharma for having put this whole program and packaging it with that time schedule. And I just hope that on another platform, on another opportunity, that we will all able to get together and give a great program again. Thank you so much to each and every one of you. Thank you, Dr. Arun, for the last closing finale topic.